get started. I don't think there's anyone here to introduce me, so I will introduce myself. And those who know me know how hard it is for me to do because I'm so shy and have trouble talking about myself. So my name is Nachum Klafter. I'm here from Cincinnati, Ohio, where I am a psychiatrist and psychoanalyst in private practice. I also teach psychotherapy and psychoanalysis. I'm in charge of the psychotherapy training curriculum at the University of Cincinnati Residency Training Program. And I'm also on the faculty of the Psychoanalytic Institute, where I'm involved in two training programs. One is to train advanced therapists that are getting advanced training in psychodynamic psychotherapy, and also in therapists who are becoming psychoanalysts in the analytic training program. And so what I'm going to talk about today with you is working with patients and families who don't believe in therapy, which is something I imagine you've at least read about before, if not maybe heard of from your colleagues or seen in your office all the times. So just a little bit of orientation to this session. The way I like to speak is that you can interrupt me with questions as we go along. I will make sure that we move on, and if I feel like the question is detracting from being able to move forward, I'll push the question to the end, but usually I think it goes better if I'm asked questions as we go along. So feel free to raise your hands, and I'll call on you when I can. And we'll probably have time at the end also. So to start with introduction, which will sort of explain what this is all about, and I intend this to be a practical talk. I hope you're going to come away from this talk feeling better equipped to handle some difficult situations in your office. And the introduction will set the orientation for what I want the talk to be about, really. By the way, so this is my office in this picture. That's where I practice in Cincinnati, Ohio. Introduction, I'm going to tell you a story about a little over a year ago. No, it's just about a year ago when I visited Stern College with my third daughter, Tahila. So we got there and we went to the Cy Sims Business School on her college visit. And what happened is they didn't tell us anything at first about the school. What they did is they had three people come in. The head of I don't know if I remember the divisions of the school properly, and my daughter's not there yet. She's in seminary this year. There is business analytics, marketing and advertising, and accounting. Those are like the three divisions of the business school. And what they did is they gave a lecture. It was a total of 45 minutes long, divided into three parts. They set up a problem. It was like a Starbucks. It's like a famous business problem. It was like when Starbucks is going to expand and take over the world. That happened already, if you didn't notice. But so they went back in time, like when Starbucks has to take over the world, and they didn't explain what business analytics. I don't know what business analytics was. I don't even really know what the difference between accounting or bookkeeping was. I didn't know any of these terms. I'm not a business guy. But they gave three lectures is what they did. And by giving those three lectures, now I understand what business analytics was. They were 15 minutes each. So they demonstrated what they're doing. Then, after they had shown, and they really had real slides from the lectures, they had, they entertained questions, they gave like a real lecture in the room. Then they started talking about the business program. But they gave us the lecture first. So we got like a taste of what it is to be in the business program. And it was a very powerful introduction to the business school, like better than talking about like when the business school was founded. Like who cares when it was founded or what, all kinds of things that would be more theoretical. They didn't do any of that. They just got right into it with us in the room. Way back when I was in college, I studied a lot of creative writing at State University of New York at Binghamton. And one of my creative writing professors in the advanced workshop, Barry Targan, he used to have a saying. He would say, "Show me, don't tell me." He would say that all the time. And he would criticize our writing if our writing was too abstract. He didn't want us to talk about things in abstract terms and concepts. He wanted action. He wanted dialogue. He wanted visual descriptions of events. He wanted almost more like a screen, like a play, like a script to a play rather than a conceptual novel. So he would say, show me, don't tell me. That's what he would say. And, you can really get a lot more out of a vivid demonstration of something than talking about it. So that's the essence of what I'm going to talk about today, is that when we have patients that are really hard to work with in therapy, we have to start doing therapy. Now, that's not necessarily easy to do, but it's much more effective to do than talking about therapy and explaining therapy. So that will be the theme going through this talk. I used to spend a lot of time explaining how therapy works. That's, I think, early in my work, I would get challenged by patients with questions like they would say, how does talking about this help me? It makes me feel worse. Or people would say things like, I understand everything about why I'm doing this, but that doesn't change anything. They would sort of protest to me like, how is this going to help me to talk about things? And it's really a pretty common question. I think most people, I don't think it makes sense to them why talking about a problem will be helpful. I think most people think they just have to do it differently. Like they just have to exercise, or they just have to change their food, or they just have to stop yelling at their spouse, or they just have to stop doing what they're doing or do something differently. How's talking about it going to help? So I would try to explain to people why talking about it is going to help, and that really didn't get me very far. That really didn't, I felt pressure to explain why it would be helpful. So now I just start doing therapy. So what we're talking about here is really resistance. And let's talk a little bit about what resistance means. I think everyone's heard that term before. And everyone knows it's sort of a bad term that we have. It implies non-compliance or insubordination or a lack of submissiveness, or that you expect the patient to be submissive. So when we say the patient is resistant, it sounds like we're calling the patient like a bad, misbehaving, not cooperative patient. I think a better definition of resistance, and this is my definition, it's an emotional flinch. What do I mean by that, an emotional flinch? If I lunge at you, you will probably blink and move back like this. If I were sitting closer, I would do it to you right now, but it's not going to work from here. And that's what's happening with resistance. When we have patients, we're asking them to talk about really uncomfortable things. They can't just comfortably do it. And they automatically, without trying, don't just get right into it. They can't. It's sort of like someone were any of you afraid of swimming? As little kids, was anyone here afraid of swimming? By a show of hands. Well, this is a very Jewish group. So if people would say just jump in the water, just do it. I don't think you would have been able to just jump in the water, And you might have known that you're supposed to. You probably could talk about how, yeah, you're right, I'm just going to jump in the water. But to actually just go and do it, it would be very hard for you to do. Your body would get hunched over, you'd have an uncomfortable look on your face. That's how to think of resistance. Resistance is a very natural reaction if you're asking people to do something very uncomfortable. It's really normal. It's not intellectual, it's an emotional reaction. And the important thing about things that are emotional is they're not really that open to reason. I mean, it might be that the person can reason with you. A lot of people that are having an emotional reaction, they maintain their ability to talk intellectually or reasonably, but it's not going to really influence them. I mean, you have to really engage with the emotions. So when we talk about people who don't believe in therapy, actually, the title's a little misleading. I think people that don't believe in therapy are people that are uncomfortable getting started in therapy. The patient and or the family are uncomfortable with therapy. That's why they don't believe in therapy. So we need to really address the underlying discomfort is what we have to do. It's not unique to Orthodox Jews. You know, I, unlike you guys, don't have a practice full of Orthodox Jews. I have a practice with some Orthodox Jews, but most of the people in my Orthodox community I have far too much to do with and can't really treat them with proper boundaries. So most of the people in my community I will refer to colleagues. I have I always have maybe a third to a quarter of my practice is Orthodox Jews, so it's a significant amount, but I know some of you are like treating like only Orthodox Jews in your practices or nearly only Orthodox Jews. So resistance is not unique to Orthodox Jews. It's true of German Catholics in Southwest Ohio. It's true of, macho men in many different cultures. And what resistance is about is it's about shame over emotional problems. People with emotional difficulties have a tremendous amount of shame, and that's why they're very uncomfortable, not just discussing it, but even thinking about it. You're like asking them to open up the most uncomfortable parts of who they are to you, so you have to expect that it's going to be very uncomfortable. I mean, just think of going to see, I don't know, a urologist, a proctologist. I don't think it's much, more comfortable than that, seeing a therapist. I think that's sort of what it's like. I'm looking at a lot of people nodding their heads. I won't ask why that is. So the shame that people have with emotional problems, it may be the person, him or herself, with shame over emotional problems. It may be the family that's ashamed that there are emotional problems in the family. And we're going to talk about those things. I think it would be good to just distinguish between shame and guilt. These are related emotions. We use these interchangeably, but I think it's helpful to understand the difference between them. So guilt, I'm going to give examples of guilt. I'm going to mostly give examples and not definitions. That's the idea of this lecture. So here are some examples of guilt. The bad thing I did is really wrong, and it's not consistent with the kind of person I should be. That's guilt. Now, what do people notice with that statement? You said still a good person. What did you say? Yes, there's for sure self-criticism in it. What did you say? External. What do you mean by external? Right, it doesn't stamp who they are as a person. It's something I did that's inconsistent with who I think I ought to be as a person. I shouldn't be having this thought I'm having. That's an example of guilt. Or, I want to do something that's bad or not allowed. And no one's allowed to interpret my typos. It's right. Maybe. So, or I know what I need to do or stop doing, and there's just no reason for me to talk about it in therapy. That's another thing that guilt will usually do. I mean, I know I have to stop doing this. Why talk about it in therapy? I know what I need to do, and I just have to get up the strength to do it, and then I'll do it. That's something guilt can do. Shame is different. Shame, here are examples of shame, and then we'll talk together about the differences between these categories. The bad thing I did shows I'm really a disgusting person. Okay, that's shame. Or what I did wasn't really bad, and I was perfectly justified. That's another thing. Does that make sense why that would also be the result of shame, or does that not? Anyone disagree? I'm seeing at least one person in the back with the last name Solomon who looks confused by that. Share with us your suspiciousness about my example. So that's someone who is feeling so much shame they have to defend against even the feelings. In other words, they're disavowing, like they can't even tolerate the idea that they did something really bad because it's so shameful. If I did this, it's going to mean I'm so bad that unconsciously I have to like frantically find a way to make it not a bad thing I did. Like I was right and he deserved it. Yeah, rationalizing would be an example of it. Rationalizing would be an example. Rationalizing may be driven by shame, absolutely. Or I'm just a terrible, horrible, disgusting person, and I can't let anyone know that I have these thoughts and desires. There'd be another example of shame. Or I'm not a horrible person, and therefore I don't have bad thoughts or desires, and therefore I don't need therapy. These are the differences between shame and guilt. So anyone what is the klalo shel davar? What is the fundamental difference between the two of these things?
I did something bad versus I am bad.
Yeah, I did something bad versus I am bad. Like the person I really believe I am or ought to be, this is not consistent with what I need to do, versus like I'm horrible. Like I'm so horrible. That's the difference between these. So shame is often a very powerful, guilt could be too, but shame more so, one of the reasons for people to feel very uncomfortable with therapy, because they're going to be talking about things that they feel stamp them as just, awful and horrible. So I'd like to talk about some of the types of objections to therapy that we see from people. And I'll do it based on diagnostic category is what I'll do. So narcissistic patients. And when I say narcissistic patients, in the DSM and the way the term is used, we usually refer to people that are, very grandiose, haughty, arrogant, cocky, superior, that sort of bragging, haughty, arrogant version of a narcissistic person. But really what I mean is anyone with very serious self-esteem problems who is spending a lot of their mental activity and energy on trying to bolster their self-esteem. So there might be many things that are in the category of narcissistic personality disorders. The DSM just chose sort of one version of this. But narcissistic patients, especially that haughty type, they only come into therapy when they're hurting really badly. Not badly, but badly. And so if you see someone come into your office who has narcissistic problems, they're already really depressed, feeling really dejected and full of shame. They're not coming in unless they're hurting very badly in the first place, because shame is such a central emotion in people with narcissistic problems. And when they start to feel somewhat better, narcissistic patients will very frequently have what we call a flight into health. Anyone know what that means? Anyone know the term of flight into health? Has anyone heard that before? A flight into health is yeah, go ahead.
Where you resume functioning until you don't. Until it hits you again and you practice it out.
But while you're in the flight into health, in order to not need therapy, okay, in order to feel that you're done with therapy, you sort of recruit a lot of willpower and motivation to suddenly live your life exactly the way you want to, and prove to your therapist, really prove to yourself, that you don't need therapy. So it's like this temporary motivation to be really, really good. It lasts 6 weeks long. That's about how long it lasts. For about 6 weeks, any of us could be really well behaved for a while in one focal area. So what keeps narcissistic patients in therapy, if they're not hurting badly, is actually empathic attunement. That's what causes them to stay in therapy. The empathic attunement to someone who's narcissistic is such a new experience for them that becomes really the glue for them to stay in therapy. So that's really the challenge. And if you can provide that experience for people with narcissistic problems, they'll probably stay in therapy a long time. And you can't always. It's just sometimes it's not a great match. It's just sometimes it's really exhausting for therapists to try to do that. This is a difficult group of people to work with. But that's, I'd say one group of objections to therapy. We frequently hear from therapists and laypersons that narcissism is untreatable. Has anyone heard that before? Yeah. So I think that is just, false. That's just really not true. Narcissism is a treatable condition, and if you hear someone say that to you, or if that was your education, we have to re-educate you. It's just not true. Yes.
It only goes back to the first bullet point, only when you're really very badly that the last time was open.
Well, again, so the comment was that only when they're hurting badly they'll be open to it. So no, I'm saying only when they're hurting badly do they come into therapy to begin with. But if you can make the connection with a narcissistic patient, which is based on an empathic understanding of what they're experiencing and communicate that to them, they will stay in therapy a long, long time. I mean, my practice is just full of so many narcissistic patients that have been with me a long time that, I know that that's true, and that's what my training was. I mean, I had a lot of training in self-psychology for narcissistic patients. Narcissistic people are treatable. They're resistant to treatment because of the immense shame in this disorder, that's like central to the disorder. But it is a treatable condition. It is not untreatable. That's just wrong when people tell you that. Yes, in the back.
There's probably a difference also with having narcissistic tendencies and having narcissistic personality disorders. Would you find that even with individuals with narcissistic personality disorder, they're treatable?
Yes, even full-blown narcissistic personality disorder is treatable. I agree that there's a difference between narcissistic traits and full-blown personality disorder, but I'm talking about the full-blown personality disorder. That is also treated. Yes, that is a treatable condition. The idea that it's not treatable, I think that narcissism is almost becoming like a bad word in the society, like we're labeling people as narcissists. I find that narcissism is most frequently diagnosed by an ex-spouse or an estranged spouse during divorce. That's the most common, situation where narcissism is identified. Yes, in the back. Elaborating on empathic attunement. So empathic attunement, briefly, empathy is the ability for me to very accurately imagine what you, for example, right now sitting in my lecture, are experiencing. Now, what is that based on? It's actually not based on knowing every culture and every sexual orientation and every age and every religion. It's not based on that. It's based on knowing your own emotions really well. And if you know your own emotions really well and you know what makes you tick, what triggers you, what does other things, you will know what makes a great many people tick and what bothers them. And you'll be able to adapt. I can imagine if I were a woman sitting in this lecture and I wanted to hear more about something someone said, but I'm worried that it's, how am I going to ask the question? And I can imagine that. And that's my capacity to imagine being you and imagine what it would be like for me to be daydreaming in my own mind, in my own body as you. That's what empathy is. And so narcissistic patients have a real problem that they've not experienced enough of that in life. They're very hungry for empathy, but they do things that are so off-putting that they don't get very much empathy. So the challenge of the therapist is to overcome that really, it's a very difficult, exhausting. I mean, narcissistic people have worn out and exhausted their loved ones, their families, their friends. They're very, very difficult people in the rest of their lives. So if you can provide an unprecedented new emotional experience in the therapy, which is based on accurately understanding how they feel and conveying it to them, even understanding the ways they feel that they're not aware of, that's really the most important aspect of it, then that is such a new experience for them that they just really want more and more of it. And then what happens is the development and maturation process starts to pick up again. They're in a state of arrested development. But they're not getting that in the rest of their lives, and they treat people in such a way that people just can't empathize with them. I mean, some of these people are really difficult to live with. And by the way, the reason we can do that as therapists is not because we're nicer and more wonderful. I mean, no one who knows me thinks I'm nicer and more wonderful than anybody, but it's because of the boundaries. It's because of the therapeutic setting. You're safer than their relatives are. You have a setup that you can be better for them. I mean, this is another lecture I give. We are able to be nicer and more understanding. It's sad to admit this, but I'm a much better therapist than I am a father or friend. I wish that weren't true. I would much rather be a better husband, father, friend than therapist, but I'm not. I'm a better therapist than those other things because you're protected. I mean, you can be like this wonderful person for 45 minutes or 50 minutes, or it's a double session, 90 minutes or 100 minutes. But like, you can't do that like 24/7 on vacation for a week with little kids. It's horrible. I mean, like, you get worn out. So that's why therapy is really for a lot of people that are really hungry for someone to understand them, like a new experience. Yes? Have I had narcissistic people recognize that they're narcissists? No. I mean, the rule of thumb is usually people who, certainly not early in therapy, maybe late in therapy, yes, but if people are worried they're narcissistic or sociopathic, they're not, okay? People who are really narcissistic or sociopathic are not worried about that. People who are narcissistic feel mistreated, undervalued, not recognized, that they're being treated unfairly, that they're being gypped. They have a lot of complaints about the rest of the world. The problem is the world doesn't understand how wonderful I am. And that's something that isn't that hard. Let's be honest. We can all identify with that. None of us think the world really, but we don't take it out on the world the way narcissistic people do, hopefully. I mean, a few of us do, but I don't know who you are yet. Yes, in the back. How do you provide empathic attunement without feeding into their narcissism? So that's a very good question. So feeding into the narcissism, I don't worry about feeding into the narcissism, because to me the problem is not that someone is cocky and arrogant. That's not the problem. I know if I were married to someone like that, that would be the problem, but that's not really the pathology. The pathology is the person is so desperate to be admired and revered, and they're hungry to be loved and admired. That's the problem. So if the person, I sometimes will feel the urge to, slap someone in the face and put them in their place. But that's not the essence of the treatment. So we don't have to worry about feeding the narcissism. There are some patients that are so grandiose and so obnoxiously defended, like they just believe things about themselves that are crazy, that they do have to be very aggressively confronted. Otto Kernberg writes about this. But that's not the mainstay of most narcissistic treatment, and most of it is done with empathy. That's how most of it is done. So I'm going to move on a little bit, and then we'll move back to narcissistic disorders. There's a lot of interest in this room. So I'm going to go on to borderline patients, another favorite group. But they literally are one of my favorite. These are my two favorite groups of people to work with. So with borderline patients, it's different than narcissistic patients. Their objections to therapy are about they're reluctant to become vulnerable. Okay? That's what they're worried about doing. They're reluctant to let someone become important to them because it's going to be so devastating when that person fails them. So it's a different type of avoidance or objection than it is for someone who has narcissistic problems. Now, there are some borderline patients that are more sort of schizoid. We think of borderline patients as being this obviously very, very needy, immediately latching onto you. But a lot of borderline patients are not like that. A lot of borderline patients actually could go a long time pretending they're not interested in anyone, and you don't realize for a long... Has anyone ever realized it's a year or two and you realize, oh my gosh, this is actually someone who's borderline, I didn't realize it. That's actually... Not all borderline patients look obviously borderline in the first session. They don't. Some look schizoid. I think the best understanding of schizoid personality is it's a variant of borderline personality with an extra layer of defense on top of it. But more often, borderline patients will plunge right in. They'll plunge right into the therapy, and then they have recurring crises when they feel rejected or abandoned by the therapist. And that's what they're afraid to do. They're afraid to become very, very attached to you, because it's going to really be a devastating crisis. It's going to be an emotional storm. It's just going to be, unbearable for them. So that's what they're reluctant to do. So, I don't know why the background changed, but we'll move on. Yes?
I think this question I have is applicable to both groups of folks. I'm wondering if in your therapy you find it essential to also work with close family members, because I feel like even if you have deep conversations with the patient or the client, that unless they are aware, their loved ones are aware of how to interact with them in a way that some of those things, instead of contributing to sort of the existence of the state it's in, that it could.
So it's a question about working with the close family members of borderline and narcissistic patients. And I would say, no, that's not true for all my patients. I would say that it's true for patients who are still dependent on their parents, and the parents are paying for the therapy, that I have to work with the parents. And I don't work with them like super closely, but I might meet with the parents quarterly or monthly or something like that. I don't think I typically work with spouses. I offer to meet with spouses if the patient wants to do it, but it doesn't usually become a big part of the therapy. There are times when I will, do a little bit of work, like a session or 2 or 3 with family, and then not meet with them for months in a row after that, but it isn't part of the work. And I don't really believe that I can ask the rest of the family to change what they're doing. I guess the people that I'm seeing who have personality disorders, I don't think it's created by the family's current dysfunction. Like, I don't really believe if I got the family to suddenly be wonderful. Also, how are you going to do that? I mean, you've met these families. Like, what are you going to do with them? But I don't think that if I suddenly had like a really healthy home, that they wouldn't have a personality disorder anymore. Like, I think like we have to, now some of my patients would like me to work with their families and make their families nicer to them. But I will usually say, well, let's assume the following. Let's assume, since your mother's not coming to my office 4 times a week like you are, and not interested in talking about her problems, she's not really going to change. Like, let's assume you're the one here. It's more likely you're going to change than your mom's going to change. And do you think it's possible to have a happy life without your mom changing? And that might make people really upset or angry for a long time. But I'd say no. I assume the rest of the world is going to get no better, and I need the patient to adapt and not the world to adapt to them. So I don't meet with families all that much. And when I do, I might really encourage the family to just be very realistic with the patient. Like, just say, like, look, like, I have a young man now who definitely meets the criteria for full-blown narcissistic personality disorder. And what I encourage the parents to say is, like, look, we are letting you live in our home rent-free. You're not working. You're not contributing here at all. We're sacrificing a lot of money for your therapy. And that's all we can do. And we hope you're going to start working soon and contribute toward it, or give us a little bit of money. But, like, we can't take you yelling at us anymore. Like, you have to stop yelling at us, or we're not going to let you live here anymore. That was what I encouraged them to say to him. But it wasn't like so they'd be nicer. It was just like, he has to stop yelling at his parents, or that's the last bridge he's going to burn. And they really couldn't tolerate it. But it wasn't like working with them. It was like encouraging them to really take that firm stand. So that's, I'd say, what my therapies are usually like with the family.
Thank you. The answer was really helpful. I was kind of thinking of the example where there might be someone who has like a substance abuse problem, and the inclination might be to evil rather than to put it to that example of kind of setting firm boundaries.
Right. So substance abuse. I'm not super experienced with substance abuse, and I usually refer out for people that have like a very active substance use disorder. But it is somewhat like enabling. I think it's a good analogy you made. Like, I'm encouraging the family to not enable, but I see it more as like reality confrontation with the patient. That's what I would think of it more as than enabling. So let's talk about histrionic patients. Yes, I'll get to your question though. Yes.
Yeah, thank you. Is it true that narcissism exists more on a spectrum than as binary? In other words, a person could exhibit qualities of narcissistic behavior without having a full
Right, so the question's about there being like a spectrum of severity of narcissism. So that's definitely true, but if you'd meet the guy I'm talking about, it would look very binary to you. There are some people where like, no, that's really, like they're in a, like it's a parsha bifnei atzma of very severe narcissistic problems. Anytime you meet someone with narcissistic personality disorder, if you feel you can help them, you should absolutely try as hard as you can to offer as much therapy as you can, because the amount of suffering and havoc they unleash on the world and the amount of suffering that they do themselves, it's so high that if you can heal one narcissistic person, it's like multiple generations of trauma that you might save, I don't know how many lives, and I'm not exaggerating. So you really should, it's worth the effort. I mean, the amount of help you can the amount of healing to the world, like tikkun olam. Sounds dramatic, but it's really, I'm serious about it. So I think that, roughly speaking, you can put narcissism into like 3 categories. There's normal narcissism, which, there's like 4 categories. People that have trouble with asserting themselves or promoting themselves. So they can't even do normal stuff to make themselves feel better. Normal narcissism, which is the energy and mental activity that, all healthy people have to devote to feel attractive, feel loved, feel smart, feel noticed, feel consequential, feel admired, feel important, lovable, attractive, count, important. And then there are people who have like greater than normal narcissistic needs, but they cultivate those needs with creative and important things. So some very high-achieving people, for example, they really do have narcissistic needs that are greater than the average person, and that motivates their high achievement. And then there are people that the narcissism creates its own dysfunction because they're so needy for admiration that they wear people out. They're nasty to people. They can't be empathically attuned to anyone because they're so focused on their own depleted pain. And in that category, I think it may as well be binary. I think it is like, in that final category, it's beyond just a spectrum. It's like really a full-blown problem. And I think the dysfunction it wreaks in everyone's lives. The best people to talk to about people who are very narcissistic would be their subordinates at work and their children. That's where you would really see the most pain and damage that's caused. Their superiors and people that they really like, and their rabbanim, their bosses, their heroes. They think that they're wonderful people because they're very good at getting the admiration out of those people that they need. But the people that can't provide them with admiration, they don't have much energy for because they're focused on their own needs. So, well, spouses are in both categories. Classically speaking, narcissistic patients, the classic presentation would be they always have one wonderful, super close friend or lover at any time that's like the greatest person in the world. But that doesn't last over time. So I think you're right. I think a spouse will usually be in that category of someone who just, doesn't do it for them anymore, isn't providing the narcissistic gratification anymore, unless that person becomes kind of like a slave and is also joining the chorus of people who love them. What happens in some families is there's like a whole collusion of worshiping this person, and it becomes like a little bit of a cult in some families. So I do want to move on to some of the other disorders, but I'll come back and do narcissism for all of you next year. So histrionic patients are very similar presentation and an avoidance and management of feelings in therapy to narcissistic patients, but it's more about affection and needing to feel loved versus needing to feel admired and important. But it's there's a lot of similarities between histrionic patients and narcissistic patients. There really is. And so the avoidance in therapy is similar in a lot of ways. A histrionic patient is likely to come into therapy when they feel sad, lonely, unloved, rejected, alone, not ignored, not noticed. And you would again you'd have the same set of challenges to keep them in therapy. So OCPD and OCD, obsessive compulsive personality and obsessive compulsive disorder. These two disorders, and some of you will be a little surprised to hear me put full-blown OCD in this category. Psychodynamically, what these disorders are about is the inability to tolerate emotions. That's what this is about. And I'm happy to, we'll talk about this a little bit, but these disorders are about people, these are people who cannot tolerate their feelings and their emotions. So they do things, they put their brains on lockdown to avoid feeling emotions. They establish rules or rituals or, orderly, they have all kinds of techniques to avoid, uncertainty, questions. So they have real difficulty with passion. They have difficulty with feeling out of control. They have difficulty with uncertainty and unpredictability. And so the objection to therapy is that the therapy is going to be stirring up all of those difficult feelings and emotions that they go to such great lengths to avoid. Now, unfortunately, the way, like the medicalization of therapy, a lot of people don't see OCD now as even a psychodynamic disorder. It's almost like they see it as a neurologic condition or something that like only responds to medication or maybe behavioral therapy, but it isn't. It's an emotional. It's people with lots of discomfort with emotions, and what you will typically see, and it's very common in our communities because we have a lot of really bright, high IQ kids, is a very, very bright child has intellectual resources available to them to deal with fear, anger, aggression, a lot of the emotions that little kids have trouble dealing with. They use their cognition to deal with those problems, and they kind of get locked into this very intellectual way of doing things early on in life, and it becomes like this pattern that gets woven into their personality, sometimes with full-blown rituals, with obsessions and compulsions, and sometimes just with like their personality style. But that's what we're seeing. We're seeing people that they learn to cope very early in life intellectually with emotional discomfort, and they're stuck in that very cognitive, cerebral, intellectual frame, and it's a very rigid life where they're just terrified of feelings and emotions. Yes?
Are you seeing like OCD behaviors as like a maladaptive coping mechanism?
Yes, I'm seeing OCD behaviors as a maladaptive coping mechanism. Like, I'll give an example. So I have a young woman in treatment who is terrified of being around knives. And when she was a little girl, she stabbed her sister with scissors, a really, really little girl. She had a lot of aggression. She had a lot of impulse control problems. And she stabbed her sister with scissors. And I don't think her family necessarily did anything so terrible, but I think she got threatened with that's, you could murder someone and you could go to jail, and I mean that's probably what most parents would say to a kid who one sibling stabs another. She was a very little girl though, and she's been terrified of her aggression. And it's not, so the most prominent thing you see is that like she can't be around knives. Like if she goes to someone's house for dinner, like all the knives have to be put away. Like, if the family goes somewhere for Pesach Seder, no knives can be around anywhere in the house. And she won't go to certain people's houses because they won't put their knives away. And it's she has almost agoraphobia because she's afraid of being around knives. But this really did start with, she was a very aggressive little girl, and she's terrified of her anger and her aggression. And so it all gets sort of like stuck in this symptom right here. The therapy is about her anger and her aggression. And she's an angry woman, a very angry woman. And she's very bad at managing her anger because she's basically done it by just winding it all up. And, she has one of these, there are people that they're always all smiles, but they look like they're about to bite your head off. My wife says they have a seething smile. That's her term for it. It's like the smile where they show all their fangs, and she has that kind of feel to her as somebody. So that's an example where OCD is that kind of presentation. Yes?
I just wanted to comment that I've also had clients over the years who, even if they're that have a lot of anxiety, finding that criteria for general anxiety disorder, but also really underneath that was a lot of anger. It was just internal. So when we worked really on anger, the anxiety got better because that was really what was going on underneath all of the externalized anxiety.
Yes, so the comment was that she's seen not just OCD, but also generalized anxiety disorder where the underlying emotion is anger, and I think you're right. I mean, I think that's a very good observation. I agree with you. I think that's correct. It's really helpful when you can see it in a patient, because then you have this whole dimension you can add to the therapy, which is to talk about the emotions that are making them uncomfortable. So, more types of objections? Yes? Intellectualizing those emotions. Well,
I'm having a visceral response, but it's very logical.
so,
Insisting that that's
right. So the comment is this an intellectualization of emotion? So I'd say that people with obsessive compulsive personality disorder, they absolutely do lots of intellectualization, but they do other things too. You know, they do other things than just intellectualization. Like they become very miserly because they're afraid their spending will be out of control. Or they become very, very, like they make all kinds of rules about, I mean, the halakha almost becomes like, it can be a canvas to put a lot of these symptoms into, but they can make all kinds of rules about sexuality or about wiping themselves after they go to the bathroom or about showering or cleaning or organizing things. So it isn't only intellectualization. It's about all different kinds of behaviors that prevent them from feeling worried that they're going to have an emotional reaction that goes out of control. So it includes intellectualization, but it's many other things too. Yes, in the back.
Do you utilize exposure therapy with these types of patients?
Well, we're going to talk about that when we get to treatment. The answer is yes, but it's not the kind of exposure in behavioral therapy, unless they have very, very behavioral obsessions and compulsions, then I do some behavioral therapy. But yes, it's exposure. It's exposure to the underlying emotions in the therapy, and I'll explain that in a little bit. So avoidant patients, this is a very shame-based group of people. They're afraid that they're going to be like outed or discovered, and they feel scrutinized and humiliated, and they feel like they're disgusting to other people. So what happens in this therapy is that they will feel disgusting to the therapist, and they become avoidant quickly to you. Now, why wouldn't they? That makes total sense. Now, here's the thing. This is an example of a psychodynamic technique. I think the common sense intuition for many therapists would be, well, I need to make my office so warm, so welcoming, so safe that an avoidant person won't feel judged or scrutinized here. Now that's true initially in the treatment if you can do that. Like that's a very helpful way to get treatment started. But ultimately, no. Ultimately, they're going to have the same feelings toward you, and it's not your failure that you failed to be, nice enough or accepting enough. It's actually, this is a wonderful opportunity to work through the problems they have everywhere. And that's, a psychodynamic principle is that the treatment, whatever problems they have with everybody, they have to also have with you. If they don't have those problems with you, you're just sort of like weaving around the problem rather than actually working on the problem. So you have to welcome, not that it's fun to do. I don't like when my patients feel like I'm mean to them or feel like mad at me. None of us like that. But that's how the treatment really works. So we're waiting for the patients to start to feel the same avoidant feelings toward you, which usually happens pretty quickly. I mean, they'll usually be pretty good, at least me. I mean, I'm not that, they will feel those things toward me also. And then you can be talking about the very problem, not like out there with the guy that she's afraid to like go on a shidduch date with, but like with you in your office, like right in your office. She's afraid of you right there. And you can work on it very directly in the room. It's a really powerful treatment when it's right in the room. So this is the easiest group of people to do that work with because they will all have the same fears towards you. So the transference is both the mechanism of cure and it's the obstacle. Because if it's too shameful and too uncomfortable, the treatment is just like intolerable. But it's also what you're going to work on. So that's sort of how this treatment works. And then paranoid patients we'll talk about. So paranoid patients, they mistrust the therapist. They mistrust everyone. They interpret interactions with you in just the worst possible way. Paranoid patients. And there's a lot of anger and hostility that they have, but they project it onto you. In other words, they really onto the world. They are feeling like everyone is mad at them, everyone mistrusts them, everyone hates them, everyone's persecuting them, but it's their own hostility and anger that they're passing on to other people. Now, I will say that this is not a great group of people to work with over time. They're not going to get a lot better. I've never seen a paranoid personality disorder person become like a histrionic or something like that. They can get better and be more functional, maybe less miserable, but they're not going to probably have a radical transformation into a totally different kind of person. This is a disorder with marginal, some improvement, but not cure. I would say, for example, narcissistic personality disorder, much more treatable than this condition. This is a more difficult. And I'm not even putting up schizoid and schizotypal patients because very, very hard to work with, schizotypal especially. So I'd like to talk about family members' objections to therapy. So with family members' objections to therapy, it's interesting. Sometimes it's a fear of autonomy in the spouse. That's why people, I sort of see that a lot with husbands, that husbands are afraid of their wives becoming more autonomous. I'm sure the reverse is also true, but I've just seen it more with husbands objecting to their wives in therapy. I don't see lots of wives objecting to their husbands in therapy. I know it's happened, but I have a lot of wives call to make appointments for their husbands.
I have a wife right now who's objecting to her husband.
I also have a wife right now, but she's not objecting to. So fear of autonomy in a child. And here I see more the mother. This is usually like the mother. It might not be that the mother's against therapy, but the mother might want to control the therapy. This could also be the father, but I just more frequently see it with the mother. Abandonment fears that that I'm afraid, what are you guys talking about? And what ideas is this therapist putting into your head? And, how, there's a loss of control over the person. There's a lot of shame and narcissistic injury to emotional problems in the family, that the family is just very deeply ashamed that anyone has emotional problems in the family. This is the stigma that we all know about, and our community is not immune to the stigma, even though it's been improved. There are concerns about shidduchim culturally, and enmeshed family systems are just more resistant to therapy. So the front comment was, duh, Dr. Clafter. I know that already. But she said it more nicely than that. But why is that? Why are enmeshed families more resistant to therapy? We'll let you do it.
Maybe because the abandonment is stronger. If someone leaves, they're leaving that loyalty.
So the way I think you're right, and I have a metaphor for it. An enmeshed family is like a really corrupt black market economy. And everyone is afraid that if someone talks to the FBI, we're who knows, I'm going to lose my income, I'm going to go to jail. Everyone is just terrified of an outsider coming in and disrupting the whole thing. It's like this underground, complicated web, and to let another person in, it's going to mess up the whole system. And so they fight therapy. They don't even know they're fighting therapy, but it's they're so involved, it's very hard for them to let someone come into the family. And when you do therapy in an enmeshed family, you become a member of the family, for better or for worse. A lot of hands went up. Wow. Yes. Yeah, I think that's that it's they're so enmeshed. You said the boundaries are so bad. So there's a famous family therapist named Murray Bowen, and he had this term, he called it an undifferentiated ego mass. That was the term he had for these families. It's like this big ball of craziness together. And so yes, you can't do therapy on one person without everyone else, Like if this person's now going to be taking, like if the daughter's no longer going to feel responsible for the mother feeling happy about things, then the mother's going to really be upset. And if that mother's upset, what's the father going to do? It becomes like everyone is, responsible for one another's emotions. And so, yes, therapy affects everybody. So did you say it was a book called The Dance of Anger? Yeah, everyone else is going to be affected if one person stops dancing. Oh, you guys know this well. I don't need to teach this concept to you guys. Everyone knows this well. Yes?
Not related to the last thing, but going up there, fear of autonomy or fear of autonomy in the spouse or the child, I find very often the spouse or parent is jealous or envious of the growth of the person in therapy, and then how will I be on par? Will I look worse than they do? Will I feel inferior to them?
Right. I think that's a very astute observation. You had something to share?
Oh, no, I was just saying, it doesn't even have to be an enmeshed family. Once things start changing, it just kind of disrupts everything, so.
Right, so I think of that as an enmeshed family because I think of a lot of families where they're very grateful for someone getting well. And that, like, if you are helping their child, they're really, really grateful. In fact, I have a family right now where... Right. So, I mean, look, we're Jews. We have enmeshment in our families. Like we all, I think, I can think of a family right now where it was a very, very depressed 18-year-old girl. I mean, suicidally depressed, very, very suicidal for like 2 years. She just had a wonderful response to therapy and medication. And she was so depressed and suicidal that the whole family was totally organized around her depression. And when she got better, they were so grateful for her getting better that there was none of this. Like, they were not an enmeshed family. Some families there's a difference between a family in crisis and an enmeshed family. A family in crisis might look enmeshed, but then when the person's not sick anymore, like, they're actually not an enmeshed family. It's interesting to see. So, and no, that was not a Jewish family, by the way, that responded that way.
Just thinking what you said about how Reuben changed where his father's bed was, right? Even that was you can look at it as a mesh. He decided where his dad was going next.
Yes, that...
As Jews, we started out that way.
I will not be the one to endorse the family dysfunction in the mikra because I've gotten into enough trouble with it, but I will quote you on the listserv, Leah. So... similar concerns with teachers or rabbis over their students and congregants. We do see that there are objections or challenges to therapy from other helpful third parties who want control, and they're afraid of losing control over people. I'm not saying that that's normal or the majority, but it is something that we're all up against when we get referrals from communal leaders. There have been sessions in previous years about how to deal with askanim. There are askanim who want lots of input into the therapy, and it becomes like a confidentiality concern. And I actually, of all people, I believed more in looking at this like a family system, and that you just have to get consent to work with the askan. A lot of people... It was interesting. People expected me to be on the other end of this. No, like, you tell them there's confidentiality, thank you for the referral, and now leave the patient alone, it's my therapy. I don't think it works that way. I think culturally, the askan is a very important person in this patient's life. Now, they do need help dealing with the enmeshment, and they need help getting autonomy, but it's not going to happen by just declaring it. It's going to be a long process. So, our communities are extended families. I mean, there are very familial parental sibling relationships. There's jealousy, there's control with, some of the Rebbe student or Rebbitzin student rabbi congregant relationship can be very intense and close, and it resembles the enmeshment in the family system also. So I want to say a little bit more about enmeshment. So there's a concept called cultural relativism. Does anyone know what that term, you have a question?
Yeah, just to make a comment that sometimes it's also about when we get rid of that problem that we lived through for many years, and that was making our whole life, our whole life was surrounded, taking care of this problem. And then when the person goes to therapy, the problem's gone. Now what do we have? That also sometimes something that's holding.
Right. So the comment was that if the family's identity or the whole way of doing business is organized around someone being sick, now the person doesn't need that same nurturing or help anymore. People don't know what to do. But that's really what I call enmeshment. I mean, that's an enmeshed family.
Necessarily their problems that are going to be come up to the surface, but it's just simply the lack of it. That,
Right. So.
and sometimes they identify with that whole life.
So.
The whole life surrounds that.
You're talking in the patient, in the identified patient, or in the family system?
The family system, once they lose the identified patient, they don't have to wake up in the morning and talk to their sister about what are we going to do with mommy today.
Right.
It's no longer there.
So I understood that, but I call that an enmeshed family. That's what you're describing is an enmeshed family. It's just they're talking about it in terms of like a thing to do rather than a person, but that is about relationships and roles that are now changing, and it's painful or uncomfortable or scary for the role to change in the family. So I want to say a little bit more about this. So does anyone know what the term cultural relativism means? What'd you say? Related to culture. That is not what it means, but that was like you'd get like partial credit on a test for that. That's what, yes.
One of the things I tried, I'm not sure, is this the idea that where there are groups that exist, the concept would be that things are in relation to other things or cultural norms?
So it's related to that. What it is it's when we assume that this is culturally normal in another culture, but it's not. This is a problem, and we are mistaking it. We're not identifying the problem because we think it's related to the culture. I'll give you an example. So I trained in Center City, Philadelphia, Thomas Jefferson University Hospital, and it was right like down the street from Chinatown. In fact, there's a beautiful like gate, with dragons on it and a big red gate and pillars to enter Chinatown right down the street from the hospital. So we would see patients from China. Now, they were not interested, they didn't speak English, they were not interested in therapy, and they would only come in when like someone became catatonically psychotic. Okay? So usually there's one person that's the spokesperson for the family that can speak English. There's a whole family and crowded, and I mean like 20, 30 people in an emergency room, and one person is translating. And so you admit the person to the hospital because they haven't left bed for 2 months and they've lost 30 pounds and really, really severe catatonic depression. And so you will describe, so this would happen every time. The resident would describe the patient and say, patient is extremely silent, doesn't talk during the entire examination. And immediately, these other really politically correct, nice, bright-eyed, bushy-tailed medical students and residents would say, oh, but maybe that's just Chinese culture. There's a value of silence in Chinese culture. That was not a good recognition of Chinese culture. This was a psychotically depressed person, and the family knew that this was wrong. So that's an extreme example, but what I want to say is, so it's when true pathology is not recognized, problems are misidentified as just part of the patient's culture. Enmeshment and resistance to therapy by the family or teacher or rabbi should not be seen as a cultural artifact. It isn't normal. I know it's common, okay? It is not normal. It is a dysfunctional family system. It needs treatment. Don't think, well, that's just what this mahalach is, or that's just what this kahila does. It isn't. It's not true. Okay? There are many, it's a family systems problem. It might be common, it is not normal. it's pathologic, it interferes with people getting help, and it isn't universal in the Jewish community. It is not.
Like the late Sahar community, something like that, you know, looking at that kind of.
Yeah, well, that was a cult. She's bringing up a cult. But there are many great Torah leaders who have wives and children with significant authority and autonomy. They do. And there are many great Torah leaders who bring their relatives for treatment, and they respect the treatment. It isn't, we're reluctant. I think it's important to stick to your guns and see it. It's a problem. It needs culturally sensitive treatment. But it is a problem. Like in your mind, you have to identify this as a problem. It's not just a problem. It's a problem that I'm going to have to work through if I'm going to help this family. Yes? How dare you confuse them? So yes, the Rebbe Rashab went to see Sigmund Freud. Right. So it's common, but it's a problem. The fact that problem is common doesn't make it normal. And it's a really important thing, and it will make it easier for you to do the work if you can see it that way. Don't just accept, well, that's how we do things. Well, I know that's how the family does things. That's why we're going to have family therapy. Yes?
No, but just to add on to what you're saying, I think that sometimes recognizing that something is culturally normative creates an even harder that brings in another layer of resistance to treatment.
Yes, and there's a term for that one too, what you're describing. It is called a shared cultural scotoma. Okay, so it is when, if the therapist and the patient are from the same culture, you both have trouble looking at the same kind of wart in your community. And it's something it's very interesting, the history of this. So there was a movement in the 70s. It was another like politically correct movement in the 70s, which was like, if you're a Latino female lesbian patient, we have to find you a Latino female lesbian therapist or they can't understand you. That was just like a sort of an experiment that went on in the 70s for a while. And, so we tried to pair, I'm going to say we, I was like a young child. I wasn't a professional in the 1970s. So the field would try to pair ethnicities, genders, sexual orientation, religion, country of origin. They would try to pair people together so they could understand one another. And what they found is, no, there's just different problems. Yes, there's a problem if I don't understand my patient's culture, but then there are just different problems if I'm from my patient's culture. And they found that patients were sometimes more resistant to admit problems to people from the same culture. They felt more comfortable with someone outside the culture. So there's sort of like we all know this now, there's no perfect solution. So I think you're picking up on that it would be maybe harder for you to go against the grain because you feel like, you're going against your own family's authority, your own rabbi's authority or something like that. So it's going to be complicated in the culture, out of the culture. So it's called shared cultural scotoma. A scotoma is a blind spot in ophthalmology. So it's like we both have the same blind spot. That's the concept. Miriam.
No, correct me if I'm wrong, I'm a little blurry on this. I think it was 2 slides ago, you had said that we need to understand the family drug as really an important part of the family. And now we're saying that we have to make sure, like there's like a thin line. At what point are you determining where it is,
So
culturally and therapeutically?
So thank you for asking that way. So I'll explain. So if Yehuda's Askin brings him to me, he says he's just playing video games all day and he stopped seeing patients and he's not learning anymore and I don't know what to do with him and I gave him a musar shmooze and he's doing nothing and you got to get his head on straight for me. Okay, so he wants to sit in the session and listen. Okay, that's enmeshed. I do recognize that Yehuda's Askin is an important part of his life. And I'm going to try to work on it, but I'm going to talk to him. I'm going to maybe meet with the Askin alone. What are all of your concerns? Okay, now let me have a session with Yehuda alone. And then the Askin may feel very hurt that Yehuda's talking to me, not the Askin. I'll have to talk to the Askin about it. And Yehuda's going to feel very torn. Well, you're pushing me against my askin, and he says this and you say this, I don't know what to do. So Yehuda is now externalizing his conflict onto the askin and onto me. It's Yehuda's own conflict. So I'll take it very, very seriously because it's basically part of his life. It's the same thing as family therapy. That's what I would do with Yehuda's father, with Yehuda's spouse, with Yehuda's mother. I will do the same therapy, basically. So I take it very seriously, and it's a problem. Now, I'm not saying, like, since it's a problem, I don't respect it. I respect people's families. I respect their enmeshed families. You know, I love my enmeshed family. But a therapist would have to contend with it, you know. You could try. You could try to send the askin to therapy. So I take it seriously, and I'm gonna take it really seriously. But I see it as it's like this is the woods that Yehuda has to free himself from to get out of these woods. And there's a lot of vines pulling him back into the woods. So that's how I see it. It is typically, I find, counterproductive to talk about cultural or religious assumptions. We have the listserv for that. And I don't find it helpful to discuss hashkafa or religious ideas with patients or families or spouses. I think I would say, you know, be better to say, well, what are you worried will happen if your son starts talking to me about his emotional problems? I find that to be much more helpful than talking about hashkafa. Or, yes, I do have a different hashkafa than Yehuda's askin, although I'm trying to get him to change his askin. I have a different hashkafa than you and the way you're raising your family. Do you feel like I want to change your daughter's hashkafa? I think that's a more helpful way to just talk, like just directly address their concerns. Now, it's not about religion and hashkafa in my mind. It's about control. If it weren't religion and hashkafa, it would be about something else. If it were non-Jews, it would be something. Just we have religion and hashkafa. Those are our culture. Like the rabbis are our culture brokers. This is our cultural stream. In other communities that are not Jewish, they have other currencies. You're very concerned that, you know, I don't look like you, I don't have the same yarmulke as you, or you're very concerned about your son talking to anyone. Tell me about your concerns. Let's hear about your concerns. I think most people will find that if you take their concerns very seriously and listen and say, well, listen, why don't we give this a try? Why don't you monitor what's going on? And when you have a concern, you come talk to me about it. It's usually reassuring. If you can talk very openly about it, it's usually reassuring. Yes, I know people can find examples where there was some really intransigent rabbi or askin that wouldn't let them talk to anyone. I know that's true, but most people, that's not the case. I also find that being very outside the culture is sometimes less threatening than being close to the culture. It's really interesting. I love telling the story. It's like a point of personal pride for me. And those who know me well, I've told it so many times. So I got a call from an askin in Williamsburg with a patient who wanted to talk to someone completely outside the community. She said, I want to see a Shaigetz. And he said, I have the perfect Shaigetz for you, Dr. Nachum Klafter in Cincinnati, Ohio. And I was, you know, and that's great. Like, I love that. I love being the Shaigetz for someone. I think I'm like almost less threatening. It's like I'm not going to even be taken seriously because I'm that far removed. And so sometimes that's helpful. Sometimes it has to be someone. Everyone has different ways to cope with their comfort. Each case is individual, but you know, we just have to start a conversation about it and talk directly about it rather than weave around it. That's my experience. So it is halfway through, and we're going to talk about how to approach therapy. Let's take a 10-minute break, and let's come back at 4:40.
If anyone is a psychologist, you would need to sign in.
Yeah, thanks. I'm the replacement class. Sure. Did you get what I'm saying about the... Okay, so We did this. Okay, so moving forward with some practical techniques. So the first thing I want to talk about with this approach to therapy, which is something that it usually requires some supervision or maybe a course in psychodynamic technique to do. Maybe supervision is the best way to do it, but this is a very different way of operating than you're used to operating with patients if you don't use these techniques. But the first thing to learn how to do is to observe and comment on affect and discomfort, okay? So as I was in this session, I was sometimes, I said, oh, there's someone in the back of the room with the last name Solomon who has a very puzzled look on her face. So I was doing that when I did that. Or, wow, a lot of you are nodding. As I'm kidding around with you guys, I'm doing that with you to a certain degree. But in a session, I'm going to describe a few examples of things. Everybody does this all the time, including myself. We all do this while we're communicating. We have emotional, nonverbal expressions of affect in what we're doing. And it is not good manners, it is not normal social behavior to comment on people's affect. It's rude and intrusive to do, usually. I get away with it, but I don't recommend doing that at home. But it's not a normal way to interact with somebody, so it feels jarring to the patient when you do this for the first time, and it will feel intrusive or weird to do. And you may sometimes feel, I couldn't say that to that person because that would really hurt their feelings. Now, you might actually be right. When I'm a supervisor, I never recommend people do stuff that they don't think the patient can handle, even if they're wrong, and even if they're in 6 months, they'll feel differently about it. Because I just think they're the ones in the room with the patient. They have to be the one to make that judgment call. But I want to give some examples. So, gee, you just giggled when you said that your mother tries to be nice. Let's say, so tell me about your mother. Well, she tries to be nice. Okay, so that's a common thing that many people do when they say something a little edgy. They giggle when they do that. So I would probably say, you just giggled when you said your mother tries to be nice. Did you notice that you just giggled when you did that? I would mention that the person giggled. I'll mention it. Or you just scrunched up your face like it's very uncomfortable to answer that question. Can you tell me more about that? You guys are giggling in the front. What is it, a private joke, or is what I'm saying seem shocking to you? What's going on?
It's a shared client that giggles.
It's a shared client that giggles. Okay, right. It's some colleagues, shared colleagues that giggle too. So these are sort of obvious examples. When you say, I don't want to say that I don't like him, can you tell me what you mean by that? That's a very common statement. I don't want to say that he's a terrible person. I'm trying to remember what it was. There's a YouTuber that I like, and he says, I wouldn't say he's a bad person. I just say he's a horrible person. That's what this YouTuber says. But that's a joke. But people say well, I don't want to say that he's a bad father. Now you can just say, take that. That's you've heard people say things like that before. I don't want to say such and such. So just say, wow. So tell me more about how you don't want to say he's a bad father. You could just. It's right in their words. It's really interesting how many ambivalent, uncomfortable, emotional things are right in the person's words. They say it very directly. And it sounds like a common expression to us. So it's oh, that's just the way people talk. No, it's very telling. When you say, oh, it's not that big a deal. How many times have you done that where you ask someone, they're talking about their panic attacks or their depression. They say, oh, it's really not that big a deal. Is that a common thing you'll hear people say? So I would say, when you say it's not that big a deal, I wonder if you're worried that it's going to sound to me like a big deal. what is it like for you in those moments when you say that? Like, are you worried I'm going to make too big a deal of this? Like, ask them about it. So these are just little examples. You learn to do that a lot. You learn to see, and these things are meaningful. This is one of the things that happens when you start doing this kind of therapy. You gain a tremendous confidence because you see so vividly. These are really meaningful moments. It's like if you're looking at a basement and there are cracks in the foundation, there are always significant cracks in the foundation. These are cracks in their armor. These are emotions that it's not that they're not trying to show the emotions to you, they're trying to not see the emotions themselves. So when people are struggling to not feel an emotion, it is always very meaningful, and you will develop a great confidence in that if you start to practice this kind of technique. Lots of hands. Yes?
I know this surprises you, but to a statement like that from a client, I might say to them, clearly it is a big deal by the way you respond. I'll be direct.
Okay, so that's fine if that works for you. I think that people have different things work for them. I think some people can do well with being more direct than others. Some people have a more gentle touch than others. I bet you that you don't do that to every patient. I bet you there are some patients... Well, and not only selective, but I think you don't even think about it in advance. Like, you have your own intuitive empathic radar, and you will naturally modify yourself to like what the person can handle. You don't have time to think about it, like, so over time you get better at it. But like, I think, that works for you. So that's great. But we all have our own styles. We all have our own ways of doing it. And the way that one person does it, another person can't. And also we're sort of self-selective. Like the people that doesn't work with, like they don't come back to see us. They'll see someone who has a gentler touch, or the people that need someone that's like going to be really confrontational. They won't see someone like Yehuda with a gentle touch. They'll go see you. So it's self-selective in a lot of ways. Like people will gravitate. You will naturally sort of just accommodate what you're sensing. As you become more empathic, you become more skillful at it. As you become more experienced, you become more confident is what you can do. So and I don't even mean to be telling you exactly how to do it. I'm just trying to show you the moments that you notice cracks in the armor, is what I'm calling it. But the armor is that they're trying to not see their own emotions. It's not that they don't want you to see they're angry. They don't want to feel angry. Yes?
Two things. First, there's another dimension. My husband always says he never believes a person who says starts with truth be told. That idea is that you have to be preemptive with that, or to tell you the truth. It's kind of the opposite of that.
No, it is interesting when someone says, like, you want my honest answer. It's like, right, it is a very funny expression, and it's like, I am so obnoxious. I will say, no, I don't. I want you to lie to me. Like, I will do that, and it's a terrible thing to say, but I am provoked when people say, like, truth be told. Well, right, it's a funny expression when people do that. Yes.
There are times, I can't say I'm so comfortable with this, but I do it anyway because it needs to be done. But what I love about doing group therapy is that
the other patients do it.
I was like, thank you. You slid right in with that. You said what your scrunch up face is looking like.
Right, group.
Holding a mirror to it.
Yes.
Do you find that once you start pointing out these observations that people might become more defensive and more careful about what they're saying and not?
So that's a great question. The question is, when you point out people's emotional little tics, do they become more defensive? So here's the thing. So an interpretation is effective if it makes the person more open. We don't care if an interpretation is true. We care if an interpretation makes someone more open. So I will not do this unless it's my sense. And again, I don't have time to think and like strategize it, but I don't do this unless it's my sense that this is going to make it easier for them to talk about the problem. So if I'm making someone more defensive, it's a very bad technique. And I can't say every intervention, never makes someone more defensive. But, generally speaking, I think that when this is done properly, it makes it easier for people to talk about stuff. Now, one of the techniques we use, I don't have up here, is that we try to talk to the part of the person that is struggling. So I do have some quotes like that. Like I could say to you, you know, it sounds like you have some really painful, negative thoughts about your mother, and you're very careful not to say anything about her that would be mean or nasty. It feels like it's like a balance. Like, you say, like, I don't want to say that I don't like her. She tries to be nice, ha ha ha. So it sounds like you've got some feelings about her that maybe she's not always so nice, but you don't want to come out and call your mother not nice. I understand that. Can you tell me, is it hard to talk about your mother without saying bad things about her? Most people will find it easier to say these bad things about his or her mother than if you can point out the struggle. So it's really the experience of doing that, I think, gives you a sense of comfort with it. So I would say, by and large, no, it doesn't make people more defensive. It makes people more open if it's being done, judiciously. But with supervision, sometimes you just even have to hear your supervisor say it for you, and you realize, like, yeah, I could say that. Like, the supervisor will say, what if you would say, what if you would say it like this? And you hear the supervisor say it, and you just know, you know what? Yes, I could have said that. I'm going to say that the next time this comes up. Like, you hear it the right way, and it clicks for you that it'll work. Or you hear your supervisor say something, you say, like, you're crazy, Dr. Clafter. I could never say that to her. She'd slap me and leave the office. You'll know when you hear it, because you do have an empathic sense as to what your patient can handle. So what we're talking about doing is making use of it to deepen the work into the patient's uncomfortable emotions. Yes?
One of the things I find that sometimes when you notice that part, that there's some way that the way you talk and the language, you give permission to that part. You know what I mean? Like sometimes I find that when you give someone permission to speak about that part in a kind way that allows them to do that, I mean, that's one thing. And the other thing is that sometimes in that whole conversation, this person will tell me, I can't do X, Y, or Z because I can't make decisions, my mother died, but they just told you 2 minutes ago about a great decision they made. So I also find it sometimes it's helpful to say, gee, really? You just did this. I'm saying that they can't do anything because they can't make decisions, they can't take, I'm a doctor, I'm a internal medicine, but I have a lot of patients in mental health, right? But I find that...
I imagine you do. Right. So these are like different, you're bringing up different kinds of techniques. So sometimes you notice the patient say something very contradictory, like they're describing themselves and it seems to be the opposite. So let me think of it. I had an example like this not too long ago where the patient was talking about how she's becoming so independent. And really there's like no independence being developed. So what you would try to do is say, so it sounds like you really want to become more independent, but it's delicate to point out that, like what you're saying doesn't make any sense to me. What do you mean you're more independent? It's very delicate. That's a person who's, probably feeling ashamed of her lack of independence or something like that. And in terms of you give someone permission, so to me that's a metaphor to say you're giving someone permission. The question is like, what does that mean exactly? Because the patients explicitly have permission in my office to talk about anything and everything. Like I've given them permission to talk about anything. Some of the times I've instructed them to talk about whatever's going through their mind. It's like based on free association. But the patient, I think it's not permission, I think, to me, discomfort is how I think of it. It's emotionally uncomfortable to talk about this. They might talk about it like, oh, I'm not allowed to say that, like that's lashon hara, or that's rechilus, or that's, but it's really discomfort. The patient is uncomfortable talking about this. It feels emotionally unsafe, emotionally uncomfortable. For me, that fits better than permission. That's just how I think of it.
Say a patient is labeled as borderline,
Okay, so I don't think that the patients I have, I would say that I don't think I have a lot of patients that are using their diagnosis as an excuse to not do something. I would probably challenge that. I think that I see patients that I've given the diagnosis because I think the diagnosis accurately captures what their limited range of functioning is. Like someone who is borderline wouldn't say, well, I can't, make a new friend because I'm borderline. I think they would say, I can't make a new friend because, she hates me and I can tell she doesn't like me. It would be I'm not hearing people do that, in the therapy I do. It's just not the way it unfolds in the therapy.
I'm saying, even though you're going through a hard time, it's okay to sometimes be happy or enjoy something. I guess it's just sometimes helping people see beyond their I'm not maybe giving you the best example. Helping people see beyond their perception, their ability.
Right. So I guess the way I'm seeing the therapy, just to respond to that, is that people have a limited range. The goal of therapy is more freedom, emotional freedom. The person, let's really straightforward example, avoidant personality and the inability to socialize. My patient doesn't say, I can't go to that party because I have avoidant personality disorder. The patient is going to say, I know I should go to that party, but I'm going to try to go. I don't think I'm going to be able to do it. So I'm not going to say come on, you can do it. That, don't quit, don't give up. See beyond your disorder. It's more as you sit here in my office, I want you to imagine going to the party. Let's talk through going to the party. Now, that's therapeutic because they're going to have the panic scrutinizing reaction in my office, just imagining it while they're in my office. So we're already doing exposure just by them imagining it. And over time, they'd be able to do more. But I don't think that my patients are doing that. The way, that's not how I see people with personality disorders operating. So, yes? No, I find all populations that I've worked with, the most painful, uncomfortable emotion is anger and hostility at someone you love and someone you need and someone that needs you. And that seems to be universally true in every culture that I've treated. Not every culture has these terms like kibbud av v'em and hotzas shemra and lashon hara. We've got all kinds of defenses that Anna Freud hadn't coined in her handbook. Now, I'm not talking about the actual prohibitions. Okay, I believe in halakha, but we have we have a very, large, rich, detailed rubric that we can choose from if we so need to limit our speech in some way. But I don't find it fundamentally different in our communities than other communities. I think that, how many cultures are people unable to report abuse by a parent? It's no different in our community. I think it's the same thing. I think these are universal things. I don't really see a lot of stuff that is, I will say there are a few things that I think are different, that present differently because of our culture. I do think that there are certain things about sexuality. It's not unique to our communities, but when you have a very, very gender segregated community, I think that it changes the way certain sexual difficulties emerge. When you have too much sexuality and hypersexuality and inappropriate exposure, you have other problems. So I think that's, to me, the biggest difference. But everything with our parents, it feels very similar to the non-Jewish world. I don't see it as a very different. So let's see. So more about how to approach therapy. Okay, so the first thing to approach therapy with people that don't believe in therapy, you need a model of treatment, okay? Now, I'm going to give you my model of treatment, and I'm going to pretend that I don't care that you think it's my model, but actually, I would love everyone to follow this model of treatment. So, but whatever your model of treatment is, you do need a model of treatment. Okay, so here's mine. Symptoms are what people do to avoid emotional discomfort. Yes, you're allowed to interpret this typo. So what do I mean? A symptom is an avoidance of emotional discomfort. What do I mean? Avoidance, procrastination, bullying, that should say, aggression, fear of conflict, inability to be assertive, denial of one's wishes or feelings, anxiety. Okay, well, just these are lots of examples. These are symptoms. And all those symptoms are ways of avoiding uncomfortable emotions. So let's think of bullying. Why do people bully? Yeah.
They feel like they're lacking something, or there's a hole there, there's something they feel empty about.
Right, so you said they feel like they're lacking, there's something they feel empty about. So there might be, you have another...
And when sometimes if it's specifically targeting a certain person, it's something about that person that makes me really uncomfortable, but I can't say it.
I'm triggered by that person or something. Yes?
Sometimes I want a connection with that person, but I'm uncomfortable being soft with that person, so I do a negative kind.
Right, so I really like that person, but I'm afraid of my longing for that person, so I pretend I hate that person. So these were just three different, very plausible formulations of bullying. They're probably all true in some people. But that's the idea, is that we look at symptoms as a way of avoiding uncomfortable feelings. So now, if you start to look at problems that way, I find that it makes treatment easier. It's like, to me, a very handy way to start to see things as conflict-based. Now, if you see a symptom that doesn't work that way, okay, like let me think of an example. If I see someone who suffers from hypothyroidism, and when they stopped their thyroid medication, they became suicidally depressed, I probably won't see that as avoiding an unwanted emotion. However, if I see someone who every time they start to get promoted or like recommended for promotion at work start to get depressed, I will probably see that depression as due to avoiding an uncomfortable emotion. Like, you've got to use all of your judgment. So if you don't see something that way, then you wouldn't try to do this therapy. So this therapy works for symptoms that you can formulate as avoiding an emotion. This very patient young man right here, yes.
How do you approach somebody with autism or on the autism spectrum?
Probably do not see the actual autistic syndrome as... I don't believe in a psychoanalytic formulation of autism in general. I think it's, we don't understand the genetics of it yet or the etiology, but I think it's a central nervous system brain disorder. However, people with autism have lots of problems because of their autism, and then they do need lots of therapy. They have self-esteem issues. They feel rejected. They feel hopeless about things, and they resort to kind of desperate ways to cope with their emotions. So they need lots of therapy for lots of issues that the autism causes for them, but I wouldn't see the autism, like, I don't believe that autism is, there could be some sort of like psychoanalytic relational approach that's going to make them tolerate stimuli more and not be autistic anymore. Like, I just don't really believe any of those theories, but people with autism need lots of therapy. People with Asperger's need lots and lots of therapy. So social skills training is one term, but a lot of that is also psychodynamic. Like, People with autism are afraid of being rejected. They're afraid of looking weird, and they're afraid to socialize, and it makes them even more awkward when they're anxious. So you can help with some of the awkwardness through this kind of therapy, but you're not going to make them into, a non-Asperger's or non-autistic person anymore. That's kind of how I would look at it. So now anxiety in general, anxiety is a word that's almost lost its meaning. It's so pervasive. There's normal anxiety, but in this model, anxiety is when unwanted emotions can't be fully contained. So anxiety is when you're starting to feel what you don't want to feel. That's what makes you anxious, according to this model. So what's an example? Well, let's see. Imagine someone who is really, really upset with his mother's anger at him. And he's worried that he's going to do something that makes his mom mad at him, and then he's going to get really mad at her for being mad at him. When he starts to get mad at his mother, start to think about it a little bit, he starts to get very, very anxious. Or imagine someone who, I have a patient who has she has a big crush on her brother-in-law. And she knows that this is really, really forbidden. She's not going to act on it. I mean, I'm not anxious about it, but she's really anxious about it. And when she starts to notice how much she admires her brother-in-law, she feels very, very uncomfortable. Now, she could not even say out loud that she has erotic feelings toward her brother-in-law. She couldn't say that out loud. As the therapy moves forward, she will be able to, I hope. But she's so terrified of these feelings, so she just noticing if he does something really nice for her sister, and she sees what like a loving man he is, that makes her very, very anxious. Very, very anxious. And so anxiety is when the feeling you're trying to not, the emotion you're trying to not feel starts to break through. That's what causes anxiety. So now let's talk about the big picture. All the treatment approaches that we do, and I'll go through them, they're all designed at helping people become more tolerant and less afraid of affects. Or when I say affects, I mean emotions. That's how this treatment works. Now, let's give examples. So psychoanalysis or psychodynamic treatment, I mean, that's the entire basis of the treatment. What you're doing is you are helping the person become more familiar in as vivid and deep a way with the uncomfortable emotions and feelings that the person has. That's what all the techniques are about in psychodynamic and psychoanalytic treatment. It's an exposure therapy. You're exposing the person to their own unconscious emotional life. And that's the whole basis of this treatment. Now, I see at least a couple people with confused looks in the back. What do you want to ask me about this?
I was under the impression that it could be a change currently, but traditionally, the focus of psychoanalysis was to help people develop insight and awareness into what was going on in their subjective internal worlds, and not so much developing comfort with the affect and emotions they felt.
Okay, so I would say that that's what insight means. What insight really means would be, it's not like an intellectual knowledge. It's like an emotion. I mean, you need to have the intellectual awareness of what's going on, but it's also a comfort and acceptance with it. And really, ultimately, insight is an emotional process and not an intellectual process. So what's an example? An example would be a man in treatment right now who he grew up in a home where his father was actually a professional baseball player, but then he got drafted in World War II, and he came back after serving 4 years in the Pacific Theater in World War II, came home, and he couldn't play baseball anymore. He had lost his spot on the team. He just wasn't going to do it anymore. He became an accountant, but he really wanted his boys to become professional athletes. So my patient is all thumbs, and he's not even like an adequate, street athlete. I mean, like, he's a klutz. And he has a memory of the first time he went to play catch with his father. His father threw the ball to him, and it's a screen memory, and he could like barely catch it, and he just watched the expression in his father's face like deflate, and then the father like had no interest in playing with him anymore. And he grew up feeling like a total wimp. Now, he actually went away to college. He got very good grades in college. He became a very accomplished professional. He's very successful. He's wealthy. He married a beautiful woman. He raised a family. He's very respected by a lot of people. He has friends. I mean, he's got a great life. And he has been under the impression that he overcame all of this. He overcame all these things. But really, he's been fighting and compensating for this all the time. And what happened is he had a tragedy that he felt responsible for, and he felt like a total failure. And he realized that all those feelings of being a wimp were totally alive inside of him. Now, he's realized that through the therapy. Through the therapy, he realized all that. But he just came in feeling tremendously depressed and didn't understand it. So this awareness that he still feels like this, really inadequate, weak wimp has been a long process. It's a very emotional process. So the insight is an emotional insight. And the way you get to those things is all the things I'm talking about. It's when you notice, like, if the patient is talking about something and you see the emotional discomfort, you see there's a conflict there, and you explore that conflict. And that's how you find your way down to the underlying. You're following the patient's emotional cues to get there. It's not like through your flash of genius. It's really through monitoring the patient's emotional expressions. So that's really what psychoanalysis and psychodynamic treatment is about. Now, mindfulness in DBT, it's really about distress tolerance. It's about like separation of feelings from actions, for example. A lot of people are terrified that if they have a thought or a feeling, they're transgressing, or they're doing something dangerous, or they're doing something wrong. That's just an example. But mindfulness and DBT are about the distress tolerance. It's distress of their emotions. That's really how this works. CBT. Well, I got this out of order, and that might let you know how I feel about CBT. CBT, what you're doing is you're replacing a very dysfunctional avoidance strategy with a more adaptive cognitive rehearsal. That's what you're doing with. Now, let me give an example. There's no point in me socializing because everyone always rejects me. So I know the classic way of seeing that with CBT is that dysfunctional automatic thought is creating the distress. But the way this therapy would view CBT is that actually, no, what's happening is you in my office, if you have avoidant personality, just imagining socializing while you're in my office makes you very uncomfortable. And this automatic thought protects you from your distress. This automatic thought is a defense. You try to replace it with a more adaptive defense, but the automatic thoughts are avoidance of uncomfortable emotions. That's how this therapy would see CBT. Behavioral therapy. Exposure and action forces a confrontation and desensitization to the unwanted emotion. Yes, Yehuda?
Can you say that again? Because I think you were saying something that flipped things around.
Okay. So with CBT, the classic description of CBT is that there's an automatic dysfunctional distortion. And that automatic distortion, that automatic thought, creates the dysfunctional emotions. This therapy looks at CBT, it flips it around. Actually, the automatic thought is helping you avoid the emotion in the first place. While you're in my room talking to me in therapy about socializing, you get very anxious. And when you say, there's no point in socializing, everyone's going to reject me, that spares you the uncomfortable emotion of considering socializing. What you're doing is you're shutting down the possibility of social. So it's not really a distortion, it's like a kind of a defense. And so what you replace the person's automatic thought with, it's a more functional thought that's less avoidant in that way. You're giving them like a better way, like they're more in touch with the emotion, but they have like a better container for it. But you're trying to help them handle the emotion in a different way. Coaching is basically, I think, a form of behavioral therapy. If you think about coaching, you're actually trying to help people do the behavior that they're afraid to do. People that go for coaching. I mean, most people go for coaching because they can't do what they need to get done. And there's an emotional, so the coach is not really getting into the emotions. The coach is just trying to like find a way to make it more, let's divide it up into a list. Like you feel overwhelmed. Let's put it into digestible bites. Let's make a schedule. Let's prioritize. The coach is helping them. But all these modalities are ways of making intolerable emotions more tolerable. And now, back to the initial thing, when you have people that don't believe in therapy, I don't think it's helpful to actually explain it. I think you just want to start doing therapy. Let me give you examples of what I mean. In the initial contact, okay, my initial contact is usually a phone call. Is that true for most people? It's either an email or a phone call. I have an email through my website or a phone call. Typically by phone. I will try to have some therapeutic interventions in the initial phone call before the consultation is scheduled. Now, what do I mean? First of all, I say, how can I be of help to you? Now, how is that a therapeutic intervention? Just to say, how can I be of help to you? Yeah, you're framing, I think you're making it easier. You're like clarifying what I'm here to do for you. You know, like how can I be of help to you? I think it makes it easier for people to start to think about and talk about their problems. How long has this been going on? Does anything trigger this, or does it happen out of the blue? Why is that a therapeutic intervention? Yes, in the back. That's right. You are, that's exactly right. You are helping them put into words and make it more understandable, and it's already less scary. It's amazing how many people don't see the association. I mean, it's weird for us almost, like that people don't see the association to like what triggers something. It's like it's hard for us to understand. But if you can think about how uncomfortable it is for them to think about it openly in the first place, it makes more sense that they can't think about the association. And so you're helping them, you know, how long has it been going on? What triggers it? Does it happen out of the blue? You're helping them already. It's a less chaotic experience that they're having. When you have these anxiety attacks, do you feel like you're losing your mind? You know, or do you feel like you want to die? I will ask that right on the phone. I mean, I'll do that already over the phone. How urgently do you need to be seen? If I offer you a session in 3 weeks, would that be okay? Or do you need to be seen right away? Why is that helpful over the phone? Why is that a therapeutic intervention over the phone? So tell me what you, say that again, I didn't.
Well, first of all, it tells you how committed they are to how important it is for them to see you in their head, and how serious they take their issue is.
Well, so that's like diagnostic.
I'm calling you because someone made them call you, you know, call a therapist and make an appointment, I'll meet you. They may be okay with 3 weeks from now, but hey, I made the call, and you know, so he's not, he doesn't have availability right now.
So they're going to feel less of an urgency already. You're saying you're putting more autonomy in their hands, or?
It may be a sign that they feel less urgency.
Right, so it's diagnostic, you know, but it's also, I think, like you're encouraging the person to tell you, like, you know, do you have to see me right away? Or, like, now I wouldn't do this just as an experiment. If I have an appointment right away, I'll offer my first appointment. But if I don't have an appointment for 3 weeks, you know, I don't have an appointment. Look, before I came here, I'm away now for 2 weeks from my office. So anyone that called me the week before I was here, I would say I'm not going to be back in town for 3 weeks. Can you see me like in 3-4 weeks, or do you need to be seen right away? So I think that you are, first of all, you are encouraging them to think about, like, how long can I wait until I get help? If I know I have an appointment on the books on January 14th, do I feel okay? That is actually a helpful thing for someone to know. I think it's also helpful to know, look, I'm taking this very seriously. I'm sorry that I can't offer. I could get you to seen immediately. Like, we have immediate help. We have help in 3 weeks. You're triaging. You're like engaging them in the triage process. This doesn't take very long to do on the phone. And I think you're already starting therapy on the phone by talking this way. Yes?
It's funny, but in a certain way, you're actually already introducing the concept of affect tolerance, right?
Yes.
So actually, I maybe can sit with this for 3 weeks.
Right.
Or maybe I can't.
Yep.
I was very struck by the model you described feels like there's a medical orientation to it, and it's not by chance. It seems to me like it's a very thoughtful process where you're stepping through a triage, the first thing that came to mind, that you're helping not only ascertain for yourself whether it's urgent, but that you're helping the kind of patient applying to the same thing as well.
Yeah, it is kind of medical in that way. You're right. But I think when you're first meeting someone, I don't want to call it medical, but like you do have to be in a triage mode because you don't know. I mean, if someone's suicidal, you're going to make an appointment for them in 3 weeks. Like, it's so inappropriate to do that. So I feel the responsibility to know, like, what are we dealing with exactly? Okay, now another thing I would encourage you to do is to schedule 2 to 3 evaluation sessions and not 1. I think that 2 to 3 evaluation sessions is much, much better treatment than 1 session. If you have the freedom to do that, it will be a much better assessment. There are not a lot of people that you're not going to need to see 3 times. I mean, how many people would you only need to see once, and that's it? So I see no reason to not make it 2 or 3 sessions. Let's schedule 2 appointments. I'm going to talk to you, or 3 appointments. I will talk to you and do an assessment that will take 2, and then I'll present for you my feedback and a treatment plan in the 3rd session. That is just a much better initial way to start treatment than 1 session. You have a lot more freedom, and most people can do that even with insurance constraints. I think they can. Yes?
What model do you do for assessment, for initial assessment?
What model do I do for initial assessment? So you will see a little bit about that, and then I'll get back to your question, describe it in more detail. You'll just in the next slide, you'll see a little bit of that. Now, another thing that's very helpful is that every initial assessment is a consultation. You should not agree to treat anyone before you've assessed them. And this is something that is, I've been supervising people a long time, and everybody, it's like a chiddush to them. Why? Because you worked in a clinic when you were initially, and you had no control. It's like not up to you who you're going to treat or not. So it's like it's like you're mukhrach, like you have no choice. It's like they come into your office and you're stuck with them. Like, we're in this mindset. If you don't know what's wrong, you don't know what treatment they need. If you don't know what treatment they need, you don't know if you can provide the treatment. So you should be very clear that everyone you meet, you're only doing a consultation. So to me, it's like, well, let's set up a consultation, and I'm going to do a comprehensive assessment. I will tell you what I think is wrong. I'll make a treatment recommendation. And if I'm someone that can provide, that treatment for you very effectively, we'll set up a treatment plan. And if I can't, I will be able to find someone that can. So now, I don't want to treat every person I meet. And if I've already set it up as a consultation, it's not like a big rejection if you decide to say no. Now, even if it isn't a rejection, let's say you meet someone and you're really not qualified. Like, if I meet someone with full-blown anorexia nervosa, low weight, dangerous electrolytes, I'm not set up to do that work. I don't have if I were working in a different kind of setting, I could do that work. I'm not, in my private practice, solo practice, I'm not going to treat someone with, dangerously low weight anorexia. I'm not going to do that. But if I haven't said in advance the consultation, I might reject them if I say, like, well, I'm not going to treat you, I'm going to send you to someone else. Patients are very sensitive, they may feel rejected. So it's just wise to set it up as a consultation. Excuse me?
Why would you say that on the phone that I'm not dealing with anorexia?
Well, I don't know. I'm giving you an example. I don't know what I'm going to find out. I'm just saying, like, I can't treat every disorder and I don't know what the diagnosis is when I meet them. Some people...
This isn't the first question that you ask on the phone, what are you dealing with, no?
Yes, it's true. If someone says I have anorexia, I will probably say, like, what is your weight right now? And I'd say, like, let me refer you to a colleague who's better equipped. If someone says they have... But, okay, addictions is another example. You will often not hear addictions over the phone. You will discover addictions in the session. If someone is drinking, a case of beer a day, individual psychotherapy by a psychiatrist in private practice is not the indicated treatment for that, and I'm not the person to do it. But I will be glad that I've set it up as a consultation so they don't think I'm just rejecting them and that I don't like alcoholism. So now, another thing is, everyone says to me, how often do I need to see you, and how long will I need to see you for? So you have to be able to say, and we get stuck with this, but the freedom to say, listen, I haven't met you yet. I don't know what kind of treatment you're going to need, so I certainly don't know how long or how frequent the sessions will be. Until we meet, I can't give an estimate like that. I think it's good to not have like I see people once a week or I see people twice a week. It's like, when I meet you, we'll see what's going on. I'll recommend the treatment that I think would be helpful, and that's when I'll present, a frequency and an estimated length of treatment. Now, this will get to your question about how to do an assessment. So another thing is that I ask about everything in the initial assessment, absolutely everything that you can think that I might want to know in the initial assessment. Why do I do that? Because if I don't, I won't find out this information. Now, I have like a metaphor for this. If you go to an internist, you're an internist? Okay. So if I come to you and I say I have a sore throat, what is the physical exam going to include?
Well, I guess it depends. If you came for an initial visit, I may just say, oh, and while you're here, but I just look in your throat and your ears. I take a full test in your ears and your throat or your lymph nodes. If you came in for a sore throat, maybe I'll listen to your chest.
So if you start to feel my lymph nodes, and I say, what the hell's wrong with you? I have a sore throat, not a sore neck. Why are you touching my neck? People don't do that to doctors. People understand that, the throat bone is connected to the neck bone, it's been a long time since I took gross anatomy. But the people understand that, you might want to auscultate my lungs. You might want to feel, let's say these lymph nodes are swollen. You might feel under my arms. You might feel my groin, right? You're going to see what other nodes are swollen. And so people let doctors do that. They accept that, we don't know. It's the same thing when someone comes to you. You can ask about anything you want to know. So what do I ask about dreams? I ask about sex and masturbation. I ask about anger. I ask about friendships, relationships while growing up. I ask about times the patient has been less observant or more observant. I ask about whether observance is a painful issue. I ask about family arguments, fights, violence, that should say. I ask about what makes you feel really bad about yourself. Is there anything that you're really unhappy about but ashamed of and couldn't tell me about today? I ask that in every first assessment. Many people have things they hate about themselves. Do you have anything like that? I ask about everything that I might want to know, because if I don't, I'll never hear about it. If you don't ask about dreams in the first session, you just don't hear about dreams. It's an amazing thing. You don't. Two people here.
How do you balance that with the client, when a client comes in and they need something, they need to unburden themselves, they haven't shared with anyone in years, and they just need someone that's going to hear them out, and they start sharing?
I probably don't I think I'm so active in the first session, the way I do an interview, that my first interview doesn't go that way. If your first interview goes that way, I wouldn't tell you to do it differently, but my first interview is a highly structured interview. Now, if the patient is starting to tell a narrative, I'm not going to interrupt them if I'm getting good material, but I'm really working as an active person. It's a pretty structured interview. It takes 2 to 3 sessions. So the model, you're saying, what's the model I use for the interview? It's a traditional, what brings you here today? How can I be of help to you? That's the chief complaint. There's a history of present illness. There's a past psychiatric history. I want to know every therapy they've ever been in, every medication they've ever taken, what the effects were, any hospitalizations. I will want to know history of any Axis I disorders, substance abuse. I want to know family, psychiatric history, and medical history. I want to know a detailed developmental history, which is not just, I'll do a diagram of a family tree. I want to know what the parents' marriage was like, affection in the house, playfulness in the house, pain in the house, violence, relationships in the family. I want to know when you were growing up, did you have a clique of friends? Were you a misfit in school? Did you feel comfortable in school? I mean, I want to know all this stuff about the entire life history, and I really ask it of everyone I've ever met. That's the model that I follow. Lots of hands going up, a lot of disapproving judginess from this group. Yes, sir. I don't have a sheet, but I have a template on my computer. Maybe. Yes. No, I find people love it. I find that they love it. I find that if you're really interested and want to know about them, and I don't think the stuff I'm asking about is trivial. I think I'm asking about things that, like, how many people when they were in middle school and high school, whether they were popular or had friends, was that not important to? How many people, like, their parents' marriage and what the relationship is like? These are important things. I find that people really enjoy the assessment, and I think that they appreciate the energy and the effort that I'm putting in. I think it usually goes well.
I find many people resent it because they want to move on to help me. Don't ask so many questions. Just tell me how you're going to help me. This is what I see. I haven't had that happen. Maybe part of it is just being a physician. I don't know, but I don't know. I've seen people from all different cultures. I don't have objections to that, really. Yossi.
This may be an obvious question, but in all of these questions and all of the answers, are you looking for a process of how we answer it, how we avoid it?
Yes.
Changes in different questions?
Right. So there's the content, which is their response to the actual information. But if I would say, so tell me about what school was like for you. School is pretty good. So yeah, the process, yes, absolutely. I'm looking and I'm commenting on process in the first session. This is the thing. You can get away with so much in the first session. People don't know what to expect out of a therapist. Even people that have been to therapy don't know what to expect of a therapist. And the thing is, most people, if you're really interested in getting to know about them, they enjoy it. I mean, I do when people want to know about me. Most of you will enjoy people wanting to know about you. And if you're there because you're suffering and you're trying really hard, people like it. I mean, and I'm not doing it because people like it. I'm just saying, no, people don't resent it, they like it. I'm doing it because I think I get the best information. I think, I get a comprehensive history. I believe in the traditional, this has been for over 100 years now. We've been doing history of present illness, past psychiatric. I mean, I probably, if someone would do a CAT scan of my brain, I probably have it in my brain. I've been doing it so many times. Why do we learn that? You should be able to do that in your sleep, doing assessments, and there's a lot of benefit to that. Yes?
Question. Would it be different, you think it's different, let's say having the client fill it out online before they come from the first?
I don't do that. I don't have anyone fill anything out online. This is going to sound so cynical. There's one thing they fill out online. Authorization to charge their credit card. that they fill out online. But no, I don't have them do any of that online. Number one, I don't have time to read it and not bill for my time. And also the assessment, it's just as Yossi asked, it's not just the information, it's how they answer the question. So they have to sit with me. And the thing is if I would read it online, I won't remember it. I won't remember the information. When I ask them and I see the response and then I type it in the computer, I'll remember it. Really typing it in the computer, that's how I remember it. It's like studying for a test. You write down the information, you learn it when you write it down. It's not that you're going to refer to your notes so much. Miriam.
How often do you find that 6 months into the treatment, the answers are actually different if you ask the question again?
Somewhat often, but not so much. And it would usually be they remember, this is something I didn't tell you when I first met. I didn't feel ready to tell you yet. And it's usually, that's helpful. That's helpful. It's okay, and I'll say well, what was it like when you told me that? Not so much, somewhat. Yes?
Do you ever come across patients who's a poor historian and really can't offer you a lot of information?
Well, yes. A poor historian who can't offer a lot of information. If that's the case, I can usually tell over the phone because I'm doing some screening over the phone. And it's probably going to be someone who's going to be brought in by a guardian or a family to help them with the history. I'm not currently seeing a Medicaid population, so I'm not seeing a lot of people with profound intellectual deficits unless families paying privately and there'll be someone there to do it. So not super often, but somewhat. The type of historian, it's really someone with poor psychological insight that would be more the challenge than someone who's a bad historian. I do make it easy for them to give the history because it's such a long, detailed history. Part of it is that when I let people unburden, I find that people get really rambly and I'm not going to get to the information that I need. So that's why I don't like to let people just sort of go undirected. I don't have and I don't find it that productive. And I might not believe that, I really feel I need to get the information. I don't want the first session to be an unburdening. I respect that someone works that way. It's just kind of not my approach. Yes?
I really value the way you laid this out. It really speaks to me. And I'm wondering what happens when after you've done this initial intake and this consultation and you realize for whatever reason this person is not the best fit for whom you should be working with. Do you then take a lot of time and energy to find the right referral source for a colleague and fill it accordingly? Or do you sort of make a general recommendation to use this type of person in daily research?
I try to do a handoff. I feel responsible. First of all, they're paying for the visit, so I feel like the service I'm providing is at least I've done an assessment, I have a diagnosis or a preliminary differential diagnosis, and I know the kind of treatment they need, and I'm going to give them specific names and numbers. If it's a colleague I think could really work well with them, I'll call up the colleague and describe the patient. So I don't, that's how I feel that it's justified for me to do a comprehensive assessment and charge significant money for it because I'm providing them a useful service. If I just say, find someone else, they kind of wasted all that time. So at least I'm sending them off with a good detailed note and a head start for the treatment. That's how I do it.
Don't you think you would feel within the first phone call or the first consultation that it's not a good fit for you, even if you didn't get all 3 sessions?
Well, probably the first phone call, I screen a lot of people away. And I'm not, I'm like many people in private practice, I'm mostly full, so I'm not trying to meet everyone that I talk to. But no, there are people that I'll work with a while. I mean, Alana and I do a lot of peer supervision. Yehuda and I discuss cases sometimes, and I will present cases to them, very difficult cases where, Alana, do you remember this woman who was a graphic designer that did not work out for treatment? Yeah, so I mean, there are people that you see and you can't tell right away. The other thing is, there are people that, I mean, I see some people with very severe personality disorders, and I don't think they're going to be a good fit with anybody. And so I'll try. Like, I probably am more likely, it's like if I think, okay, this is a severe personality disorder, someone who's really stuck in life, they need an intensive therapy, I'm going to probably try. It's kind of I just have that, like, that's the work that, like, I'm passionate about doing. Those are the skills I have. So I try with difficult people, and it doesn't always work out. So there are people that might sound like a bad fit, but I think they'll be bad fit with, like, everybody. And they often are. I mean, there's some people that are really hard to work with. And there are people that I think are a bad fit, and I can't get them to stop seeing me. I mean, we've all had that, right? Like, everyone's had that happen before. Yeah. Why are they so hard?
Why is that so hard? You try to work with them, that's it, they can't come back.
I didn't hear the last thing you said.
Why is it so hard to kind of terminate a client you think it's not worth your time?
Well, I don't know what worth your time means. In other words, like, so I have...
It's not going to fit your word. It's not going to fit. You don't feel that it's helping you and helping the client. What is the difficulty by saying, listen,
So let's say you're seeing someone with severe borderline personality disorder. So, I mean, the people that are not a good fit, it's just not like, well, like, he's into chess and I'm into backgammon. It's going to be like a very, so it's usually someone with a pretty severe personality problem. So I'm thinking of a patient right now with a very severe borderline personality structure, and she has a dissociative identity disorder, and she hates me, it seems like. But I think that would happen with probably anybody. And so, like, no, she will not stop seeing me. If she will stop seeing me, I'll let her go. But I don't really, it's not so simple. Like, I don't have someone else to refer her to that I think is going to, like, be a great fit with her. And I'm seeing people, they're difficult people, really difficult people. So it's usually a situation where it's like, this doesn't seem like it's going great, but, like, it's just really hard work. It's not like, I think, like, if I could refer her to, you, it'll be a breeze. It's not like that. So I'll usually give it a try. It's usually cases where, now, there are patients that I find, like, they're not interested in working with me, and they stop. That's usually what it will. I think usually I'll let the patient stop. For me to terminate, it's probably going to be in the first assessment phase. It's just how it usually goes. But there are cases where people have very severe problems, and they don't get better right away. It's just the nature of our work. Yes? Well, I was trained in, psychodynamic psychotherapy, supportive therapy, CBT, behavioral therapy. Those were my trainings in residency training. I felt like psychodynamic psychotherapy was what I thought was most helpful for most of the people I saw. So that's what I pursued after training, and I did analytic training. So it made the most sense to me. Part of it was the developmental model made the most sense to me. Like, I think it's the best explanation for how problems come about in the life cycle. I don't like doing CBT very much. I like doing behavioral therapy. I think I end up doing cognitive interventions because everybody does, because you can't help but correct distortions when people say things that make no sense. I mean, we always do that. But I don't like doing the worksheet, and I just don't find that, for me, very helpful. I know people that I respect that do that work, and it's very helpful. I like actual behavioral therapy more than CBT. When I say like it, like I just find it more useful. But so now I end up usually seeing people that have been in treatment before and it hasn't gone well. There's not a lot of people that have like had no therapy ever before and are coming in. It's usually people that have been on a bunch of meds and seen a bunch of people and it's not going well. So I'm seeing people with refractory problems. And it's usually people with pretty significant access to psychopathology that are most of my psychotherapy patients. Yes, I see people more than once a week. I mean, I see some people once a week. I see some people twice a week. And I see some people 3 or 4 times a week. But it's psychoanalytic treatment. That's what psychoanalysis is. So I always have like, what'd you say? Right, I don't, well, I have someone finishing up right now, so I'll have like, I mean, every time someone finishes, it's like a half day a week is open. So, so I have someone finishing and I'll have a half day opening up again. And so it'll be 2 twice a week people or 1 4 times a week person or 4 1 times a week people. You don't know how it will go. And people move and people get better. And people, there's a turnover, but I have a slower turnover. Yes. How prominent is it? I would say that 3/4 of the people I see are taking a medicine. About 1/4 of the people are not taking a medicine. I do have a bunch of patients for whom I'm only doing psychopharm because they're seeing another therapist. But in terms of if you count up the number of patients I see, total people, it might look like a lot of people, but it's very little time. Like I see them, once they're stabilized, I see them like once a quarter or once every 6 months. And it's just not a big part of my work. A lot of the people I see, I don't know how I could do the psychopharmacology with another therapist. I feel like I'll be sort of like shooting in the dark. Like I won't know what's going on, because if you're seeing someone with a really severe personality difficulty, like someone with borderline personality, and doing the psychopharmacology separately, it's like I just don't know what I'm doing. I don't know what's happening from moment to moment. So I'd rather do the medicine myself. But I do have some people that are medicine only, but it's probably a small portion of my actual hours as a month goes by. Yep.
I'm thinking about all of this, and previously in the previous slides, we talked about some of the things people say and the affect that they're sort of defending and how you respond to that. And then it made me think, this is a workshop on resistant clients. And I just thought that worked very well with resistance, because we just go with it and we're going with it, and not really making any interpretation. So your initial assessment 2 or 3, how different is it for resistant and non-resistant patients?
So what's different would be that you're being challenged to justify why you're going to do therapy. So let's say, what's the point of me talking about this? I mean, why should I come talk to you about my problems? To say, well, what problems are you referring to? I can't tell you what the point of talking about them is till I would know what your problem is. Tell me what your problem is, and then I'll tell you why it might be worthwhile to talk about. So then you'll tell me the problem, and then I'll just continue asking you. I'll just proceed with my assessment. So it's different in terms of just it's a more thorny process, but I'm basically sticking to the same process. That's kind of the theme, is that I'm not going to go and do something very different. That the best thing you can do is just be as good a therapist as you can. They're showing someone your work by doing it is much more powerful than explaining your work. Explaining your work in advance, I have found that it doesn't really work. It's taken me a while to figure this out. I used to try to explain how therapy is going to work. Now that was really good for teaching therapists. Teaching psychotherapy, it's good to explain how therapy works. Yeah. Right. So, I did feel defensive, and I felt like I had to do it. But now I just found no, just proceeding with the therapy is the best thing to do. Yes.
So I find some of that pushback when a couple months in, where it's what are you doing, and you keep interrupting me, and that kind of thing. So, and then I feel like...
The patient keeps interrupting you, you mean?
No. I ask a lot of questions,
So let me tell you how I deal with that. So that gets back to the model. So I have a model. Like if you do CBT, you have a very clear model. People that do cognitive behavioral therapy, it's a very clear model. And patients quickly understand why the session is structured the way it is. They have homework. Like it works really well for patients to understand what you're doing. So my patients very quickly understand the model is that, there are feelings that you're having a lot of discomfort with, and look at the things you're doing to avoid those feelings. Let's figure that out together. So I have this really clear model, like that's the model of the treatment. And so if they, it's like a simple, now it isn't simple work because the actual emotions are very complicated, but the model of treatment is kind of a simplistic model of treatment. So I have that to fall back on. They get the model right away. And so like they think, okay, so my job here is I'm going to try really hard to work with you. We're going to figure out these things that I've been feeling and trying to not feel. Yes, that's what we're going to do together. And like it comes back to that. Now, it takes them a while to get it down because their defenses immediately come back in, but like it's kind of like back to this. It's similar in a way to CBT in the fact that there's this very consistent frame for the therapy. So my frame is, it's not going to be like worksheets and cognitive distortions, but it's going to be free association or questions from me, and I'm going to notice what's uncomfortable. Like, what are you not able to do? Pretending you're my patient, what is it that you're here? You either are not feeling well, or you can't do the things you want to do, or the relationships you're in are not going well. Something is not working well. And if the patient is externalizing and blaming it on everybody else, okay, so that's the resistance that I'm going to have to work with. It depends on, there are all different ways that defenses come in, but there's this very clear model that we get back to, which is about how avoiding emotions is creating problems and how emotions can be so uncomfortable that they can't help but avoid them. So like that becomes very clear early in the therapy. So that's how I deal with that pushback a month or two in. That would be that we're still learning the model together. Now, people with more severe personality disorders, they're more desperate in the way they avoid their emotions. Like they have even less tolerance for emotions. They're more rigidly stuck in those ways of coping. So the work can become like monotonous or repetitive because it's that issue. It takes a long time to dig through that issue over time. I mean, it can take years with some people with very severe personality disorders. Borderline personality, narcissistic personality. I mean, how long do you think what would you guess the minimum length of time to like really borderline personality to have a substantial a century? Okay, so that would be a resistant case and a very healthy patient physically, I think. But I think it's a minimum of 5 years. Borderline personality, minimum of 5 years to have substantial. Now that the minimum, not everyone will have substantial gains, but to have substantial change in the quality of their relationships. Right? Borderline personality? Twice a week, minimum 5 years. I think that's, ballpark. Some people it might go really quickly. Yes, I'm seeing people for that long. Sure. Right. So I think we're talking for some disorders. Now, other people, it's more focal, and it's not going to be that long. Some people can make great gains in several months, but that's not a personality disorder. That's someone with a focal emotional issue, but a really intact personality, and they can do really good work, And some people just need and benefit from long-term treatment. It's not because they particularly have a personality disorder. They just have really deep issues and, what'd you say? Trauma. And deep issues, and they benefit from long-term treatment. There are some people that will function more highly when they're in therapy than when they're not in therapy, probably permanently. Now, I don't know if they'll do therapy forever. They may not want to, but they will always benefit from therapy. There are people like that. What do you mean us, Doctor? So, most people what? Would most people benefit from therapy? So I would say all therapists need therapy. Many people, probably most people would benefit from therapy, but I don't think most people need therapy. I don't. I think every therapist needs therapy. Most people could benefit from therapy, but I think it's a minority of people that need therapy. That's my opinion. Need versus benefit from. I think it's a difference. Yes?
When you're talking about people, like we've been talking about all day, that like people's resistance, you just talk with it. Like you don't explain the therapy process, but you just start the therapy process. What about relatives or askanim or abanim who call you up and have the same questions? Like, how are you helping them, whatever? Do you adopt that same mode? Like start engaging them in that conversation, or you explain to them?
I'm trying to think. So this will be the last question, so we've got to stop at 6. So Rabbanim or Askanim or people that are referring people, well, how do you help someone? How do you work with someone? I think I just say generically, well, listen, I haven't met your, student. I would have to do an assessment, and I'll get a release of information if the client agrees for me to talk to you, and I'll tell you what I think the diagnosis is, if there's a diagnosis, what I think is wrong, and how therapy could be helpful. And then what I'll do is I'll give a formulation, like I'll explain kind of what I think is wrong and how therapy describe the therapy process a little, but, not theoretically, like directly. That would be what I would do. But I wouldn't talk about it generically without meeting a patient. It doesn't mean anything. It's like too theoretical. If you meet someone and say like, okay, listen, your Talmud he feels so bad about himself. He's so worried all day long about his averas and causing other people to do averas, and he's just torturing himself all day long worrying about his averas. And I don't think that this is something that's going to respond to Musar, or he's gotten enough Musar. I don't think it's going to respond to education hashkafa. You have many other students in the yeshiva that got the same education as he did. They're not doing this all day. Like, I think he has a really severe problem with how he sees himself, and he needs to come in and talk to me. We need to figure out how he looked at himself this way, and we need to try to soften his view of himself. He's interfering, like he's blocking himself from feeling any happiness in life. He can't breathe all day long. I think he really needs help badly. I'm worried about him getting more and more unhappy, more and more depressed. So I think he'll probably benefit from medication. He will benefit from talk therapy also. I would talk to someone like that. I need the release of information, but that's how I would talk to someone. So it's well, generic is I don't know. I have to see him first, and then I'll describe. That would be how I would describe it to somebody. Okay, thank you, everyone. I had a really nice time with you. I would need to know more because I don't know. Something else that they want help with, but I just don't, I don't expect them to not be worried about the baby. That to me is nice to see you. Nice to see you. I have slides. I can send you slides.
So how so?
Email me. Andrew. Oh, it's just a skeleton. Yeah. Same as my skeleton. Yes. Sure. Yeah, I don't do that. I'm not saying it's not a good thing to do. I just don't do that. Like, I don't want to do work. I don't want to have to do a bunch of work for the form. Yeah. Well, if it works for you, there's no reason I don't do that. Right.
I'm always looking for modifications and to innovate and to make things more interesting in time.
Right.
Yeah.
Right. No, I know.
And I
other
also
people
use
that
it,
do that.
and I also use it for referrals that come to group therapy where I'm not the individual therapist. So it just gives me also a lot better picture as to who they are. But this is really interesting. I'm glad. Esther told me to say goodbye to you. She had to walk out.
Oh, okay.
She said, I walked out. I'll tell her.
Nice to see you.
Yeah.
Hi, how are you?
Good.
Shira talked about it. Really enjoyed the discussion on the law.
Oh, thank you for the feedback.
I was just curious, so if you're looking to have most people challenges, Shira felt her own high.
Only a couple of
Next year, before, so next year.
So, yes, I look forward to seeing it.